Good afternoon and welcome to another installment of our free webinars. This will be the 2013 Physician Fee Schedule 2, its impact on your bottom line. I don't know if you've had the chance to see our previous Medicare Physician Fee Schedule webinar, but it will shortly be available on the website. My name is Michael Beggs and I will be assisting you today and guiding you through our new webinar. A little bit about our company. Our company was founded in 1999 and it serves 35 unique medical specialties in 43 different states. We have approximately 1,000 plus employees with 24/7 operations. For the past 4 years, we ranked among the Deloitte Technology Fast 500, and for the past 3 years, we ranked among the Inc. 500 5,000 companies. We're a Microsoft certified partner, a SureScripts certified solutions provider, and we have our own proprietary certified EHR. The topics I'll be covering today will be the changes and additions for the Medicare fee schedule in 2013. The three major ones I'll be focusing on today are the telehealth, Preventive Services, and the transitional care management. Later on in the webinar, we'll be looking at the healthcare moving forward, how you run your practice to increase your billing, keep your billing up, and two things that you'll be having that we suggest you do is proactive visits, which you'll see is also tied into the 2013 Medicare fee schedule, and leveraging technology. Just a brief overview really quickly from 2013. This is assuming that Congress acts, which it has yet to do so, but the winners of the 2013 fee schedule are family practice, which increases approximately 7%, internal medicine 5%, pediatrics 5%, and unfortunately for radiation oncology, that goes down 14%, nurse anesthesiology goes down 4%, and radiology goes down 4%. The conversion factors. This is basically where we're looking for Congress to act. For 2012, the conversion factor was approximately $34.04, and as it stands right now, the conversion factor for 2013 is about $25. You can just see by the math. I'm not sure if you actually know the formula, but the conversion factors are obviously a part of the formula for determining the allowable rate. And just by dropping the $7.04, it could substantially affect the amount of reimbursement you receive. Later on in the webinar, we go through some of the newer codes using both the $34 rate and the $25 rate. And although the codes themselves aren't high reimbursement codes, you'll be able to see what sort of impact this can have on your bottom line. The Medicare Telehealth Services for the Physician Fee Schedule. CMS defines telehealth services to include consultations, office visits, office psychiatry services, and any additional service specified by CMS when delivered via an interactive telecommunications system. An interactive telecommunications system does not include a telephone, a fax machine, or an email system. The interactive telecommunication systems are things that you're getting more used to in your daily lives. This is your FaceTime. This is your Skype. This is your GoToMeeting. These are going to be interactions where you're going to be able to see the patient. You may not be actually with the patient, obviously, in your office, but there will be a video screen. There will be sound. It's a step before a face-to-face visit, more personable than a telephone conversation. But like I said, not exactly an inter-office visit. Who can bill for these telehealth services? A healthcare professional licensed under state law to deliver the service being furnished via telecommunication system, including physicians, physician's assistants, nurse practitioners, clinical nurse specialists, nurse midwives, clinical psychologists, clinical social workers, or a registered dietitian or other nutritional professionals. As you can see, there's quite a few people that can use the telehealth services, which is one of the reasons why it should help your not help your reimbursements, but increase the amount of reimbursements you receive, increase your revenue, increase your bottom line. It's not something that has to be exclusively done by the doctor. And given that it's telehealth, it's something that can be done a little more often perhaps, because you don't have to worry about the patient getting in. You don't have to worry about delays as much. There's essentially no travel involved with the patient. The patient can be at his or her house while doing this. And these are payments for preventive services covered by Medicare. If you've seen in some of our other webinars, which I will get to yesterday, and before, and I will get to later on today, there's been a big push for preventative services by Medicare. Medicare is essentially saying, while it's good to treat and it's good to cure, it's better to prevent. Here we have the CMS finalized the proposals to add the following codes to Healthcare Common Procedures Coding System for 2013. GO396 and GO397 are alcohol and or substance abuse structured assessments and interventions. This is, as you can see, other than alcohol. The 396 being the shorter one, 15 to 30 minutes, and the 397 being the longer, more involved one at 30 minutes. GO442 is the annual alcohol misuse screening. This is, again, is a preventative annual once-a-year thing, quick 15 minutes just to educate your patients more. And you'll see that stress throughout this webinar and throughout healthcare is we're trying to educate patients more to prevent later worse symptoms occurring. The GO443 is a face-to-face behavioral counseling for alcohol misuse. That too is 15 minutes. GO444, the annual depressing screening for adults, again similar to the alcohol misuse screening, once a year and 15 minutes. GO445, behavioral counseling to prevent sexually transmitted infectious diseases, and that is 30 minutes, a little more intensive, a little more involved. GO446 is the annual face-to-face intensive behavior therapy for cardiovascular disease, which is only 15 minutes. And finally, GO447, face-to-face behavioral counseling for obesity. As discussed earlier, these are the reimbursement rates for Northern New Jersey, and the 25 CS is the conversion factor. We'll go back to what I was saying before. The 2013 fee schedule has a $25 conversion factor, so this is what these numbers look like with the $25 conversion factor. You can review these by yourself. But as you can see, GO442, about 15 minutes, as we said before, 15 to 30 minutes, and 397 to 30 minutes, there's about a $5 difference in your reimbursement, until for the facility part fee it's a little more, but just looking at the non-facility part fee, it's about $5. So these new codes are obviously not going to set your bottom line ablaze. However, there's something that most people will be able to qualify for, as you can see. So this is going to be more of a quantity type of reimbursement to affect your bottom line. And here are the same exact codes also for Northern New Jersey, but these have the 2012 fee schedule conversion factor. If Congress acts, which most people expect Congress to do, the conversion factor will be something close to $34. It'll be very, very similar to 2012, and these will be the codes. As you can see, even in the very low reimbursement rates, around $20, $30 across the board for the non-facility fee, there's a pretty substantial difference. Here you have the average being maybe 15 to 20, and here it goes, I mean, it doesn't skyrocket, but percentage-wise, that's a pretty nice increase to $20 to $30. This is one of the new codes, and one of the main reasons why family and internists are getting the percentage boost, as I said earlier before, they would be considered one of our winners in this graph right here. Let's go back. Like I said, there are new codes, And this is where a lot of the increase comes from. Approximately 5% of the increase is going to be due to these TCM codes. The other 2% is likely going to be from RVU increases. The new codes are a transition from inpatient acute care, a skilled nursing facility, and other facilities to beneficiaries' primary physician in the community. You're allowed to use one TCM code within 30 days of discharge, and these codes are going to address a largely overlooked area of treatment. It's supposed to help with the assuming of responsibility for the beneficiary's care and to reduce the gap between when a person is discharged and when a person goes and sees their primary care physician. It's also used to establish or adjusting the plan of care to reflect required and indicated elements and to reflect the result of communication. So basically, it's to give a better service. It's a more thorough follow-up. It's hopefully to reduce readmissions. I'll mention this again later. This kind of goes to some of the Medicare shared savings programs, your ACOs. What they're trying to do is have more quality of care and less care. We want to see less people going back into the hospital being readmitted, and this is a way that that Medicare hopes that it's going to work. That by following up after a person has been discharged, there'll be less lapses, less times where there'll be a setback, because we're hoping that it'll be caught, it'll be discussed, and it'll be prevented. The 99495 service is of moderate complexity. It requires the following elements: communication, direct contact, telephone or electronic, with the patient and or caregiver within 2 business days of discharge. The medical decision making of at least moderate complexity, inter-service time 40 minutes during the service period, and a face-to-face visit within 14 days of discharge. And the allowable amount for this is approximately $164. So as you can see, this is a lot higher reimbursement than some of the G codes, the new G codes, but it's unlikely that you're going to be able to bill this as much. And we have the high complexity of 99496. Again, communication, direct contact, telephone, electronic, with the patient and or caregiver within 2 days of discharge. This is, like I said, high complexity, so the service time has increased from 40 to 50, an extra 10 minutes. And the face-to-face visit will be within 7 days of discharge instead of 14 days of discharge, cutting it in half. However, to compensate for that, the allowable amount is now approximately $230, an increase of about $70. Now, the healthcare in review. Basically, if you look past from 2012, 2011, 2010, and now in 2013, there's a big changing in the paradigm of how a physician's practice now increases its revenue. A lot of the responsibility has been shifted from the patient onto the doctor. The doctor needs to educate the patients. There's going to be a lot of more proactive visits, as we saw the G codes before, and what else later on, the annual wellness visits. What CMS is trying to do is to have the doctors get the patients into the office, have them see the doctor, not just the office, and really prevent more diseases or more injuries or more sicknesses from occurring. Like I said before, the goal is, while curing a disease is good, preventing a disease is better. And 15 minutes, although not a lot, is not really a substantial amount of time. 15 to 30 minute reviews with the patient over a course of time, it may be that one thing they tell them that prevents them from developing a serious disease. They can change their lifestyle, change their eating habits, change their drinking habits, change their smoking habits. You never know. Like I said, they're looking for thorough and efficient treatment. This, again, very much like the ACOs. They're looking for quality, not quantity. They want you to spend more time with an individual, make sure the individual knows how they're being treated, what they're being treated with, what could happen later on. And then to help you with this technology. You've already seen in the TCM, that's your iPad, your iPhone, your FaceTime, Siri, your tablet. And then later on we'll get into some of the other technologies that MTBC uses to help their providers. But technology is going to be a big part in helping to increase your revenues moving forward. Preventative services, like I just discussed. Proactive, and as you can see, Care Connector. Care Connector is one of the services that MTBC provides, and that is what we use to help search patient databases, the doctor's patient database, to scan and see what interactions are patients available for that. For the most part, patients don't even know. If you scroll right to the bottom, the annual visits, that is the Medicare annual wellness visit. That's a link directly to a previous webinar that we did. I believe during that webinar, I forget the exact amount, but it was something along the lines of 30 to 40% of Medicare patients didn't even know that they were eligible for an annual wellness visit. The annual wellness visit didn't actually cost the patients any money. There was no copay, and it was a pretty substantial reimbursement for the doctor. So that's why the onus is on, it's on the doctor now, it's on the provider to educate his or her patients into seeking out these services. We want to get people into the doctor's office, make sure that they know that their services they're available for, because this is essentially free money. If it doesn't cost the patient and it doesn't cost the doctor, and if nobody uses it, it just sits there not getting done, that's really a lost opportunity for the doctor, for his or her bottom line, and really for the patient. There's no point for the patient to miss out on essentially free counseling and free prevention. And then, as the Pinky Bank suggests, a penny saved is a penny earned. Saving money is making money. One of the ways that you can save money now, especially like what I said before with technology, is moving to paperless system. To do that, you would need an EMR. The paperless system not only is a little bit safer, a little more secure, a little bit more organized, you don't have to buy paper. I mean, that's what paperless means. I know some of our doctors that have switched over to the EMR have reduced their consumption of paper tremendously. One practice in particular that I was at about a month ago told me they went from buying 1 or 2 boxes of paper per month to now, since they transferred over to the EMR, they use about 1 box per quarter. So again, you're not going to be saving $30,000 on an EMR because you're not using paper anymore, but everything counts. That's $1,000 at least right off the bat that you don't have to worry about. And like I said before, it's more secure, it's easier to use, there's better access, more available access. And then also, as I'm sure most of you know, the meaningful use bonuses. The government's been encouraging people to move over to the EMR and have provided pretty large bonuses to the doctors as incentives. Again, another way to increase your bottom line. E-statements. E-statements are electronic statements through your email. These are very low, if not zero costs, as I'm sure most of you send out hundreds, if not thousands of emails a week. Thankfully, we're not charged on that. And the retail and online seems a little bit out of place, but I get a lot. Oh, my patients don't want to use these statements. My patients are an older demographic. My patients still go on the computer. And yes, I understand and appreciate that there's an older segment that is still used to getting a bill in the mail. However, these are the same people that are probably on Amazon.com. They're the same people on eBay. They're the same people that go online to do some shopping, and most, if not all, of those bills come online. So it's as far as it might seem to some of our patients, to some of your patients, it's really moving just as a society to e-statements. So in the next few years, if not sooner, I think e-statements will be a great way for people to save money. There'll be no stamps, no delay in mailing, and you can also have links to patient health portals to automatically pay online right through your e-statement. Again, telehealth, as we mentioned before, putting your iPad and iPhone to work for you. This reduces time, and this really helps on the patient side. From the patient side, it doesn't force the patient to take the drive, the train, however they get to the doctor. It really reduces that for them. So now the 20 or 30 or 40-minute commute to the doctor's office is now essentially eliminated. That saves a great deal of time for patients, and from the doctor's end, it hopefully and may reduce no-shows. It may reduce delays in waiting for your patient to show up, because they essentially don't have to go anywhere. They could be sitting and just pop on their iPad, hop on FaceTime, hop on GoToMeeting, and there you are getting your reimbursement for providing a service. And then, like I mentioned before, the ACO models. We've also have webinars on the ACO models. If you check out our website and then go through the webinar section, I won't get into that too much right now. But the ACO is just a way of compensating providers and groups for essentially providing better care, more efficient care, and saving money for, among other reasons, having less readmissions into hospitals. And this is, again, where the TCMs come in, because this is supposed to not only give you a reimbursement for your additional work, it'll also tie in together with ACO models, because if TCMs work as they are supposed to work in a hypothetical situation, a more informed patient, a patient with more follow-up and more follow-through, more importantly, should likely be readmitted less often, and that affects the ACO reimbursement. You can increase the amount of shared savings. These are some of the other value-added services that MTBC as a company provides. You see the e-prescription, the MTBC patient health record. This will give information to your patients, help them access some of their records, eventually help them schedule, help them pay securely online. We have our EMR, which is free of charge at the 5% rate. Just a lot of things. I mentioned Care Connector before. We have the 800 number. These are things that where MTBC as a company, we go to work for you. This is how you save money and therefore make more money. All right, we're on to the questions section of our webinar. And I have two questions actually three questions now on the TCM codes. The first question is, and I'll kind of answer them together, how many times may the TCM code be billed, and when is payment expected? That code is payable once in the 30 days following a discharge, and it's paid once per patient per discharge. It really goes to the treatment of the primary care physician or the community physician, and it's unlikely that a person is going to be seen by more than one of those type of providers. And the claim is expected to be paid at the conclusion of the 30-day post-discharge period. And the other question is, does the TCM include a face-to-face visit? As I said before, let me just hop back up there. I believe it's right. Yep, there you go. The moderate complexity one has a face-to-face visit within 14 days, and the high complexity one has a face-to-face visit within 7 days. However, if during this 30-day period, generally if you have additional face-to-face visits after the first face-to-face visit, those visits should be billed and paid separately. So if you see the patient with, say, 2 times face-to-face visits after the 30-day period, you would be able to bill both the TCM code and that additional visit. These are some important links: the press release, the fee schedule. If you're a better person than me, you have 1,300-page PDF, something to do maybe over the upcoming break. I don't know. I won't be doing that, but bless you if you try to tackle that. And then the other link was up here for our webinar, www.mtbc.com. We have a blog, we have our webinar. There's a lot of great information on there, so that is another important link. Thank you again. My name is Michael J. Beggs, Jr. I'm one of the VPs of Client Relations Management here at MTBC. Feel free to send us an email or contact us at info@mtbc.com. I would just like to thank you for taking your time and sitting here. I hope you have a good day, and if you guys need any help, any questions, feel free to contact us. Thanks. Bye.